Among women with urgency urinary incontinence, up to 20% of them may also have fecal incontinence. And constipation is often viewed as an unwanted side effect of these antimuscarinic medications used to treat women with UUI. The primary aim of this study was to characterize change in FI symptom severity using the St. Mark's score in subjects with double incontinence after treatment with darafenacin. Important secondary aims included characterizing change in FI frequency, quality of life, and treatment improvement. We also looked at OAB symptom bother and quality of life, and also characterized adverse events. Our hypothesis was that in patients with double incontinence, treatment of UUI with an antimuscarinic medication will improve FI symptom severity by 8 weeks. This was an open-label cohort study in women with concomitant UUI and FI, electing antimuscarinic medication for the treatment of their urgency incontinence. UUI symptoms met a level of moderate or greater bother on the UDI-2, and fecal incontinence symptoms met a St. Mark's score of greater than or equal to 12. Using the St. Mark's MID and the noted standard deviation, a sample size of 30 subjects provided an 80% power with a type 1 error probability of 0.05. Including a 15% attrition rate. Baseline questionnaires included the St. Mark's, Fecal, OABQ. Patients also did a 7-day bowel diary. After 8 weeks of treatment, a repeat bowel diary was performed, as well as the questionnaires, and we added the PGII as well. 28 women completed the study with a mean age of 67 and BMI of 30. The majority were white and postmenopausal. Approximately 34% noted IBS symptoms, 22% used fiber supplementation, and 16% had surgery for FI. The mean St. Mark's score was 18, and the median number of weekly FI episodes was 7. Primary outcome revealed both a clinical and statistical improvement in St. Mark's score exceeding the MID. Notably, 68% of subjects met the MID for the St. Mark's, and 64% of subjects reported FI symptoms were at least much better on the PGII. The number of FI episodes per week, proportion of continent bowel movements per week, and the number of continent days per week were all significantly improved. And all subscales of the Fecal noted both a clinical and statistical improvement after 8 weeks of treatment. As would be expected, both subscales of the OABQ showed both clinical and statistical improvement. The most frequent adverse events were dry mouth and constipation, and 28% of subjects did need a dose reduction during the study. The results of this study show that it is important evidence to guide providers treating patients with double incontinence, and we should consider this earlier in the treatment algorithm. Thank you for your attention. I look forward to our discussion.
Thanks for Bill Gibson, University of Alberta. Certainly would fit with clinical experience that often you'll treat their OAB and cure their fecal incontinence as well. Some of the patients we see with fecal incontinence are constipated and we give them laxatives. Some of them are having diarrhea, we give them Imodium. Did you look at the cause of the fecal incontinence for these patients? Were they all constipated or did they all have loose stool to start off with?
Yeah, great question. We did do a Bristol stool scale, and the median score was 4. We took out the extremes of diarrhea as well as constipation. The mean kind of aimed more towards between 4 and 5, so a lot of them, we just took first come, first serve, so a lot of them tended to kind of go toward the more loose stool range.
Any other questions? Great. Thank you so much.
Thank you.